The following audio is part of a certified educational activity titled Systemic Sclerosis-Associated Interstitial Lung Disease, or SSc-ILD, Expert Insights on Current Management and Emerging Therapy. Access the entire activity and complete the post-test at www.peerview.com/VPF. Downloadable slides and practice aids are also available.
Hello, I'm Kristen Hyland from the Cleveland Clinic. Welcome to this educational activity on scleroderma interstitial lung disease. Joining me in this discussion are Dr. Donald Tashkin from David Geffen School of Medicine at UCLA and Dr. Richard Silver from the Medical University of South Carolina. Thank you both for coming in to talk about this important topic.
Thank you, Dr. Hyland. It's good to be here.
Happy to be here too.
Systemic sclerosis, or scleroderma, is a chronic connective tissue disease of unknown etiology characterized by immune dysregulation, inflammation, widespread small vessel vasculopathy, and progressive interstitial and perivascular fibrosis of the skin and internal organs. Interstitial lung disease is common in scleroderma and a leading cause of morbidity and mortality. Symptoms include dyspnea, which is exertional in the beginning, but can occur with less exertion as the disease progresses. Non-productive cough is another common symptom. To understand the challenges facing our colleagues in pulmonary and rheumatology, I will turn to our panel, and Dr. Silver, let me start with you. Please discuss the importance of early recognition of scleroderma and common challenges you have experienced with this diagnosis.
Thank you, Dr. Hyland.
You're welcome.
Systemic sclerosis represents a major clinical challenge for physicians and patients. For the patient, systemic sclerosis is associated with great uncertainty of outcome and development of manifestations that are potentially lethal or can reduce quality of life. Systemic sclerosis is uncommon and is designated an orphan disease with a high unmet medical need. Diagnosis can often be delayed, which adds to the patient burden. To understand these changes, let's take a look at a case. 35-year-old woman presented with a 6-month history of bilateral hand stiffness and swelling. Initially, she noted puffy hands with paresthesia of all fingers except the fifth, and she was frequently awakened from sleep with bilateral hand pain. She underwent carpal tunnel release with improvement of paresthesia. However, she continued to have puffy, stiff hands and lost her ability to make a full fist. The patient actually had a 15-year history of Raynaud's phenomenon with blanching and cyanosis of the fingertips on cold exposure, and she recalls having been told a blood test for antinuclear antibody had tested positive. In the beginning, her cold-induced vasospasm caused few problems, but as the years went by, digital ischemia became more pronounced, and she began to develop painful sores on several fingertips. These digital lesions were slow to heal, and at times white, chalky material would extrude from the ulcers. She also complained of dysphagia and heartburn and was found on barium swallow to have esophageal dysmotility with gastroesophageal reflux. Her PCP prescribed proton pump inhibitor therapy, which improved her GI symptoms. When serologic studies confirmed a positive ANA, she was referred to my practice. Early symptoms of systemic sclerosis include Raynaud's phenomenon, which may precede skin changes and visceral disease by several years, especially in patients with the limited cutaneous form of systemic sclerosis. In the diffuse cutaneous form of systemic sclerosis, Raynaud's phenomenon may begin shortly after or coincident with the onset of skin disease. Puffy fingers may be the presenting sign in diffuse scleroderma patients. Other symptoms which are nonspecific and somewhat vague include malaise, fatigue, arthralgia, and myalgia. Gastroesophageal symptoms or dyspnea are common presenting symptoms. This slide shows the classification criteria that were established in 2013 from a task force of the American College of Rheumatology and the European League Against Rheumatism. So a total score of 9 points is needed for a definite classification of systemic sclerosis. One can achieve this score of 9 points simply by having proximal skin involvement, which is skin thickening of both hands extending proximal to the metacarpal phalangeal joints. One can also achieve a score of 9 without proximal skin involvement. For example, skin involvement of the fingers, puffy fingers, will give you a score of 2 points, or sclerodactyly of the fingers distal to the metacarpal phalangeal joints but proximal to the PIP joints will give you a score of 4. Certain fingertip lesions, for example, digital tip ulcers or finger pitting scars, can also give you scores of 2 or 3 respectively. Telangiectasias give you a score of 2. Abnormal nail fold morphology on capillary microscopy gives you a score of 2. And pulmonary involvement, whether it be pulmonary arterial hypertension or interstitial lung disease, gives you a score of 2. Raynaud's phenomenon gives you a score of 3. And the presence of one of the 3 major scleroderma-specific autoantibodies, the anti-centromere, the anti-topoisomerase 1, or the anti-RNA polymerase 3 autoantibody, can give you a score of 3. I'll illustrate some of the features of the diffuse cutaneous form of systemic sclerosis, which is defined as proximal limb or trunk involvement with skin sclerosis. As noted earlier, these patients often have a short history of Raynaud's phenomenon, or sometimes Raynaud's phenomenon occurs coincident with the onset of skin changes. And these patients are at increased risk of renal crisis and cardiac involvement. These are also the patients who are at the highest risk of severe lung fibrosis. The second major form of systemic sclerosis is a limited cutaneous form, which was previously referred to as the CREST syndrome. These patients have distal skin sclerosis and, like the patient I presented earlier, often have a long history of Raynaud's phenomenon prior to the development of any skin or internal organ involvement. These patients are susceptible to late-stage complications, including pulmonary arterial hypertension and also severe gut disease, but also, I should note, they are susceptible to interstitial lung disease. In patients with systemic sclerosis, sine scleroderma, we'll often see Raynaud's phenomenon, typical systemic sclerosis serology or nail fold capillaroscopic features in the absence of skin thickening. These patients are at risk of organ-based or other vascular manifestations. Finally, systemic sclerosis overlap syndrome will present with features of one of the 3 subsets together with clinical and investigational features of another autoimmune rheumatic disease such as lupus or dermatomyositis. Systematic investigation of newly diagnosed cases of scleroderma and regular follow-up is important to identify complications that might require management. This systematic approach allows proactive management and has been associated with overall improved survival in cohorts of patients with systemic sclerosis. On this slide, if you begin in the beginning, in the center, you'll see the importance of screening for internal organ involvement in systemic sclerosis patients. And here one is screening for the various internal organ complications that may arise. Pulmonary hypertension, we screen with Doppler echocardiography and yearly PFTs with measurement of the DLCO. If those are suggestive of pulmonary arterial hypertension, a right heart catheterization is performed to confirm the diagnosis. For lung fibrosis, we obtain pulmonary function tests with measurement of the diffusion capacity at baseline and every 4 to 6 months during the first 3 years. And consider a baseline high-resolution CT scan and follow-up CT scans if there's any change in the patient's symptoms or in their pulmonary function test. For gastrointestinal symptoms and nutritional issues, we use system-based investigations such as barium swallow, gastric emptying studies, and if there's a suspicion for small intestinal bacterial overgrowth, a hydrogen breath test. For renal disease, particularly for patients with anti-RNA polymerase 3 positivity or early diffuse scleroderma, we recommend blood pressure monitoring 3 times a week, Prednisone should be avoided, and if necessary, the dose should be kept to less than 15 milligrams per day. And an estimated creatinine clearance and urinalysis should be obtained at regular intervals. And finally, for cardiac disease, an echocardiogram is done every year. Electrocardiogram is done at baseline and in follow-up if there are any cardiac symptoms. If there are any suggestions of heart failure, then a troponin or BNP should be obtained. And if a patient is in high risk or has cardiac issues, then a cardiac MRI can be considered.
Thank you for your insights, Dr. Silver. What do you think the biggest barrier to making a timely diagnosis of scleroderma is in the population of physicians not as familiar with scleroderma as you?
I think that many patients present with these vague symptoms, as I indicated before, arthralgia, myalgia, puffy hands, which can present as carpal tunnel syndrome as in the patient I described earlier, or may be construed as rheumatoid arthritis or other rheumatic diseases. So the diagnosis can be very difficult to obtain early, but the sooner the patient is referred to a rheumatologist, the more likely they are to have an established diagnosis.
Do you have any tips for the pulmonologist that might be seeing one of the systemic sclerosis scleroderma patients so that they recognize those patients when they come through their door?
That is a difficult group of patients because they don't have the typical features of scleroderma, but I think that they almost always will have Raynaud's phenomenon. So that's a very important clue to the pulmonologist who may be evaluating a patient for dyspnea or cough. So if they have symptoms of Raynaud's phenomenon, certainly if they have dysphagia, nail fold capillary changes, any of the serologic features of scleroderma, then a prompt referral and collaboration with a rheumatologist would be indicated.
How would you recommend someone perform nail fold capillaroscopy who might not have access to a wide field microscope that you have in your office?
So nail fold capillary microscopy is a very useful test. It's certainly non-invasive and not expensive, but it is difficult to find experts who are able to do it routinely. So you can usually use a dermatoscope or magnifying glass to look at the nail fold capillaries. This isn't as ideal as a wide field microscope or video microscopy, which is done at some centers, but I would say that probably the best and easiest way would be a dermatoscope.
Next, we'll examine the challenges of diagnosing interstitial lung disease in patients with scleroderma. Dr. Tashkin, can you describe your experience in diagnosing these patients?
Yes, I'd be happy to, Dr. Hyland. Let's look at the case of Janet, who at age 35 presents with diffuse cutaneous systemic sclerosis. She's had her diagnosis made of systemic sclerosis 1.8 years previously. She was enrolled in Scleroderma Lung Study 2 because of the fact that she had symptomatic scleroderma-related interstitial lung disease. She was assigned to treatment with oral cyclophosphamide. She had dyspnea on exertion of moderate degree and impaired exercise performance. She also had a dry cough. She had borderline restricted ventilatory impairment with a forced vital capacity a little bit less than 80% of predicted. Her diffusing capacity, however, was well preserved, which is a little bit unusual. Usually the diffusing capacity tends to be lower than the vital capacity at presentation of scleroderma ILD. She had moderate skin thickness. The extent of her interstitial lung disease in the most severely affected lobe, which in her case happened to be the left lower lobe, was as follows. She had a close to 32% involvement of the left lower lobe with interstitial lung disease consisting of a combination of ground glass opacity and fibrosis. So ground glass opacity represents an opacity, hazy opacity, through which normal lung markings can be seen. And the fibrosis is indicated by the presence of coarse linear markings or reticulations with architectural distortion. The extent of fibrosis was much less than the ground glass opacity. It was about 3.5% at baseline. Now, this slide shows the course of Janet's disease over the 24-month duration of the trial. So we measured lung function, specifically forced vital capacity and diffusing capacity every 3 months for the full duration of the trial, unless the patient discontinued prematurely, in which case the patient was asked to return for the last follow-up visit at 24 months. So here we see that at 3 months already, Janet's vital capacity has declined by close to 7% and her diffusing capacity by over 16%. So we can see that at 3 months already, Janet's interstitial lung disease has apparently progressed, and it progresses even further at 6 months. Then as we proceed over the course of the study, then by 24 months, she's had a very marked reduction in her vital capacity, almost 34%, with a diffusing capacity of close to 26%. So you might say that in retrospect, this patient might have been managed a little bit differently in the real world. As part of the clinical trial, she was maintained on the medication that she was assigned, but there would be a rationale for actually switching therapy or adding, say, an antifibrotic on top of her cyclophosphamide when she actually developed clear evidence of progression, which was obvious after six months of her involvement in the trial. So here we see at 24 months, the marked progression of her interstitial lung disease is indicated by the extent of interstitial lung disease, which is 32% in the right lower lobe at baseline, now is over 60%. And the amount of fibrosis has increased from 3.5% to 21%. Up to 90% of patients with scleroderma have evidence of interstitial lung disease on HRCT. I have to say, however, that these findings come from specialty centers. And recently there was a report from Norway in which all the patients with scleroderma in that country had their HRCTs at baseline reviewed by an experienced rheumatologist who found that only about 50% of the patients with systemic sclerosis in Norway had HRCT evidence of interstitial lung disease, somewhere between 50 and 90%, let's say. Now, the HRCT is the most sensitive and specific diagnostic measure to assess the presence and extent of interstitial lung disease. But you could have ILD, interstitial lung disease, evident on HRCT and still not have any significant lung function abnormality. So according to a study that was published some years ago, about 40% of patients with evidence of interstitial lung disease on CT developed a reduction in their vital capacity over time. Most of the reduction occurs within the first few years after diagnosis. And in that particular study, only about 15% of patients actually lost more than half their lung function, usually within the first 5 to 6 years, so that the vital capacity declined to less than 50% in those patients who are at the greatest risk of dying from interstitial lung disease. So how do you know who is going to progress? The rate of progression is very heterogeneous. It varies markedly from patient to patient. And there are a number of predictive factors that might predict which patients are more likely to progress more rapidly. And we'll review those features a little bit later in the presentation. One of the features that has been proposed as an important, significant prognostic factor for predicting the rate of progression of interstitial lung disease in systemic sclerosis patients is the baseline forced vital capacity. So here we see data from a cohort at one particular center. Actually, these data were published some time ago. The patients who had a vital capacity of less than 55% of predicted had the greatest rate of progression of disease, and over a period of 10 years, the survival in this subgroup was only 55%. Those who had relatively well-preserved vital capacity, so an average around 87% of predicted, had the least rate of progression, and those with a vital capacity in between those two extremes had a decline also that was intermediate between the rates of decline and the other two subgroups, so that over 10 years their survival was 74%. So the vital capacity at baseline is one of the factors that may help predict which patients might decline more rapidly. So let's go on to another study. This slide actually illustrates findings from another study that was published more recently by Go and her colleagues from London. The cohort from which the data were derived for this study actually was also from a single center. It consisted of about 330 patients, all of whom were followed for up to 10 years or longer. All had baseline HRCT scans. So those who have less than 10% involvement were classified as having limited disease. Incidentally, this limited disease doesn't mean limited cutaneous scleroderma, it means limited interstitial lung disease. And then those on the right side, greater than 30%, those patients were classified as having extensive disease. The intermediate group actually consisted of those who had an extensive involvement on their HRCT between 10 and 30%. So they were called indeterminate. At that point, it was useful to combine the HRCT findings with the spirometric findings. So if they had indeterminate involvement on their HRCT and their vital capacity was greater than 70% of predicted, they had limited disease. If they had indeterminate HRCT findings and the vital capacity was less than 70%, they had extensive disease. Now we'll see how well, whether or not you had limited or extensive disease predicted the progression of the disease and survival after about 10 years. So those with extensive disease had a far greater rate of progression and far lower survival at 10 years compared to those with limited disease. So these data are actually survival data, but there were comparable graphs for progression-free survival. So progression-free survival would involve patients who not only survived, but did not have excessive declines in the lung function over the period of observation. Disease progression in this study was defined as the reduction in the vital capacity of more than 10% compared to baseline. That's a relative decline of more than 10% from baseline, or a relative decline in the diffusing capacity of more than 15% from baseline. Now, another study, actually, the Scleroderma Lung Study 1, found somewhat similar findings. In Scleroderma Lung Study 1, the extent of fibrosis on the baseline HRCT was also actually turned out to be the most robust predictor of the rate of progression of the interstitial lung disease. So at baseline, the extent of fibrosis was evaluated visually by two radiologists. And if there was disagreement, the third radiologist broke the tie. And so the classification was as follows. A mild fibrosis was defined as an extent of fibrotic changes, reticulations with architectural distortion between 1 and 25% in the zone of maximal involvement, usually the lower lung zones. Here, the zone was defined not as lobes, but rather as area equivalent zones, upper, middle, and lower of the lung. The moderate fibrosis, or grade 2 fibrosis, was defined as an extent of fibrosis in the zone of maximal involvement of between 26 and 50%. Moderate fibrosis, or grade 3, was defined as an extent between 51 and 75%, and you can see the fairly extensive reticulations and honeycombing, and very severe fibrosis is more than 75% involvement. And as I said before, the zone of maximal involvement was usually in the lower lobes. So as I mentioned before, there are a number of features of systemic sclerosis that have been proposed as predictors of the course of the disease. There are clinical features. We already mentioned the low baseline vital capacity and extent of interstitial lung disease on HRCT. Low baseline diffusing capacity is also an important predictor. The presence of diffuse as opposed to limited cutaneous systemic sclerosis implies a greater risk for actually developing interstitial lung disease. However, once interstitial lung disease has developed, patients with limited disease, as Dr. Silver indicated, are not exempt from developing interstitial lung disease. Once it has developed, the rate of progression thereafter is similar between those at limited and diffuse disease. So recent onset, most of the progression occurs in the first few years after diagnosis, and there are a number of biomarkers that have been proposed. Some of these biomarkers still need to be validated as really valid predictors of the progression of the disease. So in summary, interstitial lung disease is a significant cause of morbidity and mortality in systemic sclerosis. Diagnostic modalities to assess the presence and progression of interstitial lung disease include pulmonary function tests consisting of both the forced vital capacity and the single breath diffusing capacity for carbon monoxide. HRCT is also important, certainly at baseline. It may show patterns consistent with scleroderma ILD, and the pattern that is characteristic of scleroderma ILD is nonspecific interstitial pneumonitis, which includes presence of both ground glass opacity and evidence of fibrosis.
Thank you, Dr. Tashkin. When you're using HRCT and pulmonary function testing to stage your patient into limited or extensive interstitial lung disease, does that then influence how you're going to treat your patient or follow your patient?
I don't think it would influence how I'm going to treat the patient. I think that all patients with interstitial lung disease should be treated. But when one follows the patient, then one looks for changes in lung function. It's easier to measure lung function serially than HRCT because of the cost of the radiation exposure with HRCT. It's been recommended that vital capacity and diffusing capacity be measured every 4 months. If the vital capacity and or the diffusing capacity declines by an amount that we would consider to suggest progressive interstitial lung disease, 10% or more vital capacity, 15% or more diffusing capacity, or 4 to 9% of vital capacity plus 50% of DCO as proposed by the OMERAC group, then what I would do is actually repeat the pulmonary function test, because pulmonary function tests have a lot of variability due to factors unrelated to pathology, maybe due to patient or effort, technical problems, diurnal variability, seasonality, et cetera. So I would repeat it. If the pulmonary function changes are sustained, then what one might do, if the patient is already treated, and consider switching therapy or adding a second drug on top of the first. If you began with immunosuppressive therapy, you might want to add an antifibrotic, although there is no clinical trial evidence yet that that strategy will be successful, but it's at least hypothetically that's a reasonable approach. However, if you're not sure that the lung function changes really represent progression, then you could repeat the HRCT, which would give you actually confirmation that progression really has occurred. Now also, sometimes patients will become more dyspneic in the absence of pulmonary function changes, and that increase in dyspnea could also represent progression of ILD for which the lung function tests are not sensitive enough to detect, in which case you might want to obtain an HRCT. So if you look at the HRCT, the repeat HRCT, you've already obtained at the baseline, then you'll be interested to see whether or not there is evidence of progression. So you could detect by eye whether or not it's worse, or actually more accurate assessment would be to use a computer algorithm that will allow you to quantitate the extent of involvement. So what increase in extent of involvement would represent true progression? I don't think that we have enough data to actually determine what those real thresholds are, but in our laboratory, somewhere between a 2 and a 4% increase in the extent of involvement on HRCT would probably represent true change or true progression.
Do you think there's any role for either submaximal or maximal exercise capacity measurements with 6-minute walk or CPET in following your patient with their interstitial lung disease?
So we have an interstitial lung disease clinic in our center at UCLA, and the 6-minute walk test is very popular and is very commonly used in following patients with, for example, idiopathic pulmonary fibrosis. However, it becomes a little problematic in patients with systemic sclerosis because they may be limited in their exercise capability by factors other than their lung disease. And also, because of the skin involvement in the digits, the usual method of monitoring oxygen saturation, well, it doesn't work that well. Of course, you could use an ear oximeter as well. So we, therefore, I generally shy away from using the 6-minute walk test to follow patients with scleroderma ILD.
Now we'll take a closer look at the current state of scleroderma ILD management and explore emerging therapeutic strategies. Dr. Silver, can you review the current treatment recommendations for scleroderma ILD?
The recommendations by EULAR for skin and lung disease were published in 2017 and include methotrexate, which improves the skin score in patients with early diffuse scleroderma. However, its effects on other organ manifestations have not been established, and I would note that it should be avoided in patients who have evidence of interstitial lung disease because its potential toxicity could confound the interpretation of changes in lung function in such patients. Cyclophosphamide should be considered for treatment of scleroderma interstitial lung disease, in particular patients with progressive ILD, and this has a strength of recommendation of A. And I would note that the Scleroderma Lung Study 2, which compared cyclophosphamide to MMF in patients with scleroderma ILD, had not been published at the time of the 2017 update of the EULAR recommendations. And based on the evidence we now have from SLS2, I think one could conclude that MMF, mycophenolate mofetil, should be considered for treatment of scleroderma ILD, in particular for patients with progressive ILD, and that it too would have a strength of recommendation of A. And finally, hematopoietic stem cell therapy, HSCT, should be considered for the treatment of selected patients with rapidly progressive systemic sclerosis at risk of organ failure and death. Careful selection of patients with scleroderma for this kind of treatment and the experience of the medical team are of key importance.
So, Dr. Silver, How do you follow your scleroderma patients with and without interstitial lung disease, and when and how do you initiate therapy?
Well, the first thing I would say is you have to listen to the patient. So not only the pulmonologist listening to the chest for crackles or evidence of interstitial lung disease, but listen to the patient in terms of what he or she can do, how they may have had to modify their exercise or their tasks so that they can perform their daily tasks. Keeping in mind that patients, because this is a systemic disease, may limit their activity because of muscle, joint, skin manifestations, and may not necessarily experience dyspnea. Although if you push them and had them do their task at their normal rate pre-illness, they may often have dyspnea. So listen to the patient figuratively and literally. I look at the pulmonary function test, particularly the spirometry and the diffusion capacity. And when those are abnormal, I get a high-resolution CT scan. There are certain patients that I will follow very closely, certainly patients who have abnormalities at baseline in their lung function with no other explanation, or patients who have abnormalities on their CT scan plus dyspnea or cough. These patients are candidates for immunosuppressive therapy. If they're not symptomatic, then I follow their pulmonary function tests very closely, often in those patients who have early diffuse disease with other markers of high risk for development of ILD, such as being of African American ethnicity, having topoisomerase autoantibodies. These patients I may follow every 3 to 6 months, particularly early in the course of their disease in the first 3 to 5 years. If they develop changes on their spirometry or diffusion and have HRCT changes, either ground glass or fibrosis, as Dr. Tashkin pointed out, these then would be patients who would be candidates for immunosuppressive therapy.
Do you now start patients on MMF as opposed to cyclophosphamide given its safety profile? What is the role for cyclophosphamide at this point in time?
Well, you'll have to ask Dr. Tashkin that for his opinion, but in my practice, and based on my own experience with these drugs, as well as the very robust data from the SLS2 study, I start with mycophenolate mofetil, MMF, and only use cyclophosphamide in those patients who either cannot tolerate MMF or are progressing despite the use of MMF. And in such patients, I usually will opt to switch them to cyclophosphamide, and I generally will use the IV monthly pulse cyclophosphamide rather than the daily oral cyclophosphamide, which was used in the SLS1 study.
Dr. Tashkin, do you have anything to add?
No, I agree. Both cyclophosphamide and MMF have similar efficacy, as indicated in the scleroderma lung study too, but mycophenolate is better tolerated. And for that reason, I would choose mycophenolate over cyclophosphamide as an initiating therapy. But if patients didn't tolerate the mycophenolate, then obviously switching to cyclophosphamide would make sense. And I too would favor pulse therapy with intravenous cyclophosphamide over oral cyclophosphamide.
Dr. Tashkin, how long do you treat your patients with scleroderma ILD?
That's a very good question. We really don't know how long patients should be treated because we don't have any long-term studies that evaluated different lengths of treatment to determine whether or not the length of treatment made a difference in terms of outcomes. In scleroderma lung studies 1 and 2, patients were treated with cyclophosphamide for 1 year or mycophenolate for 2 years. And a long-term follow-up of those patients indicated a rather high proportion of the patients died, mostly from scleroderma lung disease. And my belief is we did not carefully follow the patients with regard to what additional treatment they might have received after they left the trial, but it's my impression that most of them did not receive further therapy. that suggests to me that the treatment needs to be longer than 1 to 2 years. So we don't know exactly how long, but my inclination would be to treat the patients for perhaps up to 5 years. And if based on serial measurements of lung function, if the interstitial lung disease appears to have stabilized, then I would withdraw their medication but continue to follow them with periodic lung function tests. And if they then develop evidence of progression after the medication was stopped, I would reinstitute it.
And how often should we be getting chest CTs on our patients?
Again, that's another good question. I think whenever there is some doubt as to the clinical significance of changes in lung function, because lung function measurements are associated with a lot of variability, and so it's possible that one might find a decline that really is due to factors other than progressive lung disease, perhaps related to just patient effort or technical factors. And so if there is ever a question as to whether or not the disease has progressed based on the lung function changes, I would obtain an HRCT, which would provide the most specific evidence of progression of the disease if indeed progression has occurred. Also, if a patient becomes more symptomatic with breathlessness, despite apparently stable lung function, I would also consider obtaining an HRCT scan to determine whether or not there is evidence of progression not reflected in the lung function. Also, I would consider the possibility of pulmonary hypertension developing in such patients, and in that case, I would actually obtain a follow-up echocardiogram and possibly right heart catheterization.
And Dr. Silver, for those patients that don't have evidence of interstitial lung disease, how do you follow them longitudinally to identify those that may develop it in the future?
Well, it goes back to what I said at the baseline, that you listen to the patient and you use your ancillary test, which would be the pulmonary function test. Probably not the 6-minute walk test, as Dr. Taskin indicated earlier. And if there is a change in their exercise capacity or a change in their spirometry and diffusion, then one generally should get an HRCT to compare it. Hopefully there's a baseline HRCT. And then based on the degree of change in the physiology and the pulmonary function test and any change on HRCT progression, one would then either begin immunosuppressive therapy, or if they've been on immunosuppressive therapy, consider adding additional therapies.
So you would recommend that all scleroderma patients should get at least annual pulmonary function testing?
Yes, that's been my practice. So I obtain them at baseline. For the early diffuse patient who's at high risk for ILD with all of those markers that we discussed earlier, I will see them back in 3 months and get PFTs every 3 months during the first few years of their disease. But in any patient, I like to get them back and have PFTs done annually, not only looking for evidence of interstitial lung disease, but as Dr. Taskin mentioned, any evidence that might suggest the development of pulmonary arterial hypertension.
On that latter note, if you find that the diffusing capacity decreases out of proportion to the change in the vital capacity, you should suspect the possibility that the reason for this disproportionate reduction in diffusing capacity might be due to the development of pulmonary hypertension.
Great, thank you. So we know that scleroderma remains difficult to treat with limited treatment options. Few randomized studies have been conducted. Effect sizes for existing drugs are small, and there's no approved disease-modifying therapy. Patients may therefore receive several different immunosuppressive therapies for complications involving skin and internal organs. Their impact is modest, especially in the skin, and they have associated with adverse events that have important lifestyle consequences. There are some emerging therapeutic options in scleroderma interstitial lung disease, and the next 2 slides show drugs that are in development that target either the immune system, the vascular system, or are antifibrotic. These drugs are currently underway, and I think we would all agree that it's important to consider our patients as clinical trial participants in order to further the science behind scleroderma interstitial lung disease. In this first slide, bortezomib, a proteinase inhibitor, is in an early phase 2 study. Patients are on background MMF, and the primary endpoint is safety, looking at adverse events. Dabigatran affects the vascular system. It's a direct thrombin inhibitor. That study has fully enrolled, and it is also a safety trial. Dabigatran may have some antifibrotic effects in addition to affecting our vascular system. MMF, mycophenolate, we've heard about that already in the setting of scleroderma lung study number 2. There's ongoing study in early scleroderma interstitial lung disease. MMF is an inhibitor of lymphocytes. Rituximab, which has been used as escape therapy in severe scleroderma interstitial lung disease, is being studied in a phase 3 trial of connective tissue disease-associated interstitial lung disease, which includes patients with scleroderma. This is an anti-CD20 monoclonal antibody targeting B cells. SAR 156597 is an anti-IL-4, IL-13 monoclonal antibody. Its primary endpoint is the modified Rodnan skin score, but the interstitial lung disease is a key secondary endpoint. Likewise, tocilizumab, which targets is a phase 3 study recently completed. Its primary endpoint also is modified Rodnan skin score with interstitial lung disease as a key secondary endpoint. There are 2 studies focusing on nintedanib in scleroderma-associated interstitial lung disease. The first study is the Census trial. This is safety and efficacy of nintedanib in systemic sclerosis-associated interstitial lung disease, with the skin being a key secondary endpoint. This is an ongoing study that is fully enrolled. 580 patients have been enrolled in this study, making it the largest scleroderma interstitial lung disease treatment trial to date. The Census On is a continuation study of these patients. A second study that is allowing patients with later stage scleroderma interstitial lung disease with a progressive phenotype is the pulmonary fibrosis interstitial lung disease trial that also includes patients with rheumatoid arthritis, hypersensitivity, pneumonitis, and other types of patients with a progressive ILD phenotype. This slide shows more details of the Census trial. This is a global multi-center trial that randomizes patients in a 1-to-1 schema of nintedanib 150 milligrams twice daily to placebo. And then these patients are followed for up to 100 weeks, although the primary endpoint is assessed at 52 weeks. It was designed to be a trial to evaluate the safety of long-term treatment with nintedanib in patients with scleroderma-related interstitial lung disease. Patients may be on background methotrexate or mycophenolate according to the EULAR guidelines. At the completion of 100 weeks, patients are offered the opportunity to enroll in Census On, the open-label follow-up study. The primary endpoint is annual rate of decline in FVC measured in milliliters per year, assessed at the 52-week endpoint. The key secondary endpoints, as I discussed, are changes in baseline modified Rodnan skin score at week 52, as well as change from baseline in St. George Respiratory Questionnaire total score at week 52. I'm going to pass the baton to Dr. Tashkin, who's going to take us through trials that are done with pirfenidone.
Yes, thank you, Dr. Harlan. There are 2 trials of pirfenidone in patients with scleroderma ILD. One trial, which I won't discuss in any great detail, is the Scleroderma Lung Study 3. This is a trial of pirfenidone on top of background therapy with mycophenolate. All patients do receive mycophenolate. All participants in the study receive mycophenolate. They cannot be enrolled in the study if they have previously received mycophenolate for longer than 3 months, or have received other potential disease-modifying anti-rheumatic therapy. This study is currently actively recruiting patients. There are 17 centers throughout the U.S. So the LOTUSS trial is actually a completed study. This is an open-label trial of pirfenidone that primarily focused on the safety and tolerability of pirfenidone as the primary endpoint in patients with scleroderma ILD with lung function and skin involvement and quality of life as secondary or exploratory endpoints. So it's a small trial of 63 patients who were randomized to 2 different groups based on the frequency of titration of the pirfenidone medication. So pirfenidone is manufactured in capsules. Each capsule contains 267 milligrams of pirfenidone. All patients are titrated up to a final dose of 3 capsules 3 times a day. And so that would equate to a total maintenance dose of 2,403 milligrams per day. In the so-called 2-week titration group, patients received 1 capsule 3 times a day for 1 week, and then they stepped up to 2 capsules 3 times a day for an additional week, and then they stepped up to 3 capsules 3 times a day, which they continued during the maintenance phase, which lasted for an additional 14 weeks, so a total of 16-week trial duration. The second group were randomized to receive 1 capsule of pirfenidone 3 times a day for 2 weeks. And then they stepped up after 2 weeks to 2 capsules 3 times a day. And then after an additional 2 weeks, they stepped up to 3 capsules 3 times a day for the remainder of the trial. Practically all of the patients experienced an adverse event. Treatment emergent adverse event simply means an adverse event that occurred during treatment. More patients reported these adverse events during the titration phase compared to the maintenance phase. The most commonly reported treatment emergent adverse events were similar to those that were found in the pivotal trials of pirfenidone that led to its approval for the treatment of idiopathic pulmonary fibrosis, namely nausea, headache, and fatigue. Additional adverse events of lesser frequency included rash and gastroesophageal reflux symptoms. More patients discontinued treatment because of adverse events in the 2 versus 4 week titration group, that is 5 versus 1, respectively. Interestingly, all discontinuation events occurred more than 3 weeks after the patients reached their full dose of pirfenidone, regardless of what titration group they were assigned to. Patients were allowed to take background therapy with mycophenolate or oral cyclophosphamide, and it turns out that over 60% did receive mycophenolate in addition to pirfenidone, and fortunately, the mycophenolate did not add to the adverse event profile of pirfenidone.
So, taking care of these patients, especially if they progress, can be quite challenging. Talk about the strategies you have at your institutions in regards to managing these patients. with a team approach, pulmonologists and rheumatologists working together, and what that looks like?
So we have a connective tissue disease ILD clinic and also a working group that meets every week that is composed of pulmonologists, rheumatologists interested in scleroderma and ILD, radiologists, and pathologists. And we discuss cases from a diagnostic standpoint, patients who present with some type of interstitial lung disease. We're not sure that it is related to scleroderma or some other connective tissue disease. So we look carefully at the various characteristics of the patients, including their autoantibody profile. We also are interested in following patients are presented who may have already been diagnosed with connective tissue disease-related interstitial lung disease, who are on some type of therapy and which may lead to some toxicity or may fail to prevent progression of the disease, and we discuss then therapeutic options in those cases. It's a very useful collaboration. It's a learning experience for all of us who participate in this program. The pulmonologists learn from the rheumatologists and vice versa, and I think it helps facilitates better management of these patients.
Dr. Silver, how does it work at your institution, and is it useful to collaborate amongst experts, especially when trying to identify maybe some of the comorbidities that are contributing to scleroderma interstitial lung disease or dyspnea associated with this underlying condition?
Well, as you know, since you were at my institution before coming to the Cleveland Clinic, we have a very robust relationship between the rheumatology program and the pulmonology program. So we see each other frequently. We share patients amongst the two groups. And in addition, we have a weekly conference that includes not just the pulmonologist and the rheumatologist, but also a radiologist trained in chest radiology and interpretation of HRCT scans. Occasionally, we'll have the pathologist present as well. And I think it's essential that we work together as a team. We always, as Dr. Tashkin said, end up learning a great deal from one another. And it is extraordinarily helpful for the patient. And in terms of those comorbidities that can influence the course of the ILD or the patient's perception of their exercise capacity, those issues also can be discussed. For example, sleep apnea, something that rheumatologists don't think a lot about, except in other conditions, but in ILD that could be a contributing factor. Management of the gastroesophageal reflux and the role that it may play in the progression of ILD, and the suitability, for example, of a patient for a potential lung transplant if they fail these other therapies. These are all very important issues that can be discussed in a multidisciplinary capacity.
That brings us to the conclusion of today's discussion of scleroderma interstitial lung disease management. Doctors, do you have any final thoughts?
Yes, Dr. Hyland, I think we find ourselves on the cusp of a very exciting time in the approach to the management and the treatment of patients with scleroderma ILD. Over the past 20 years, we've learned that immunosuppressive therapy can improve lung function for some scleroderma ILD patients. And in the next 5 to 10 years, we're going to learn if additional therapies added to immunosuppressive therapies, particularly antifibrotic therapies, we're going to learn if that approach will further increase the survival of our patients with scleroderma ILD.
And I agree with Dr. Silver. In addition, we're going to accumulate more evidence regarding the effectiveness and safety of hematopoietic stem cell transplant for those patients who do not respond well to immunosuppressive therapy with or without superimposed antifibrotic therapy. Also, of course, there is the lung transplant is also an option for patients who fail all more conventional therapeutic options. I think one of the problems, there are some questions that remain unanswered. We still don't know the ideal duration of therapy for patients with scleroderma ILD, and nor is there complete consensus on when therapy should be initiated and whether or not and how frequently HRCT scans should be repeated or may be repeated in patients with scleroderma ILD as part of the follow-up management of these patients.
Thank you so much, Dr. Tashkin and Dr. Silver. We hope you found the activity informative and useful to your practice. Thank you very much for participating.
Thank you for listening. Download materials and complete the post-test for instant credit at www.peerview.com/VPF. This activity is supported by an independent educational grant from Boehringer Ingelheim Pharmaceuticals Incorporated. This activity has been jointly provided by Penn State College of Medicine and PVI, Peerview Institute for Medical Education.